Hello, my name is Pablo Caro. I am the chairman of the Cardiothoracic Task Force of the ESPR. I have the great pleasure and honor to have three big friends from Latin America today at the ESPR webinars that are going to speak about endemic infections from the region. And it's going to be, they are going to speak one after the other. We will start with Dr. Claudia Lazarete, who is a pediatric radiologist from Lima, Peru. She is the head of Hospital Niño, the Instituto Nacional de Salud del Niño San Borja. He has been the head of the department from 2014 to now. And now he is also the head of pediatric radiology of the Department of Reso Centro. Afterwards, Mariana Rodero will speak about, she is also a pediatric radiologist. She is working at the Children's Hospital of San José do Rio Preto from Sao Paulo, Brazil. And finally, Dr. Carlos Ugas, also from Lima, Peru, will conclude the session. He's also working in the same hospital of Dr. Lazarete. Only to remember some things, remember you can ask all the questions that you want. You only have to write them in the chat function that you have below. Just start with the session. Claudia, you will be the first. Thank you very much. Claudia, we cannot hear you. We cannot hear you.
Now, can you listen to me?
Now.
Okay, perfect. Sorry. Okay. So, hi everyone. Thank you to the ESPR and to the Slarp for the invitation. I'm going to talk today about manifestation of CNS tuberculosis. CNS tuberculosis is a severe form of extrapulmonary tuberculosis, and it's crucial for radiologists to be aware of this disease for early diagnosis and prompt treatment. Well, I have 10 minutes to talk about this, and I hope to finish at that time. No disclosure. The objectives of this talk will be review the main presentation of forms of CNS tuberculosis and review the complications. CNS tuberculosis, there is increasing prevalence of TB in immunocompetent and immunocompromised people. As many as 9 to 10 million cases of TB are detected worldwide every year. 239,000 children younger than 50 years died from tuberculosis in 2015, with more than the half cases being in children younger than 5 years. It has various manifestations, symptoms are not specific, and diagnosis can be challenging, so the role of the imaging is crucial for an early diagnosis. Manifestation of CNS tuberculosis, we can divide this in two main groups, intracranial involvement and spinal canal. So we will talk about intracranial involvement due to the time, and you have to consider meningeal and parenchymal involvement and also consider complications. Moving on to meningeal involvement, tuberculous meningitis is the most common presentation. Tuberculous meningitis is mostly due to the hematogenous spread of Mycobacterium tuberculosis. However, it can also occur secondary to extension or rupture of the subapial or subependymal focus to the subarachnoid spaces or into the ventricular system. We have two types, leptomeningitis and pachymeningitis, with possible complications as hydrocephaly, vasculitis, infarcts, and neuritis. Here I show you three different cases. The first, you can see the inflammatory exudate surrounding the cerebral arteries in the basal cisterns. In the second case, we have leptomeningeal enhancement on the right cerebral hemisphere. And in the third case, dural thickening and enhancement after contrast showing the pachymeningeal involvement. Moving on to parenchymal involvement, tuberculoma is the most common presentation of the parenchymal involvement of tuberculosis. In imaging, we can see focal lesion of high signal in T2 weighted images with low signal in the periphery and brain enhancement. Casus granulomas have central low signal in T2 and T1 and heterogeneous enhancement after contrast. They can be confused with lymphoma, neurocysticercosis, and mycosis. This is a 5-year-old boy with multi-drug resistant TB, and I show you here in FLAIR a bilobulated cystic lesion with high signal in T2 and periphery edema. There is no significant restriction in the center of the lesion, and there is peripheral enhancement showing us no calcifying tuberculoma. This is a 10-year-old boy with suspected brain tumor, and the patient came with a focal lesion in the cortical subcortical junction of the left frontal lobe with a low signal in T2, low signal in T1 and T2, and surrounding edema. There is also avid enhancement after contrast. The spectroscopy shows increased peak of choline and lactate and lipids with low peak of NAA. We really thought that this patient had a tuberculoma due to the characteristics of the lesions, but the neurosurgeons decided to go to OR due to they thought that this was a brain tumor, and the result after pathology was a tuberculoma. Another presentation is the tuberculous encephalopathy, which is described almost exclusively in infants and children. Cerebral damage due to an immune reaction we saw, and there is no non-scarce meningeal involvement. This is a 12-year-old girl with headaches and TB contact. And here you can see a high signal intensity in T2 in the bilateral thalami and also in the posterior limb of the internal capsule, and just a few enhancement in the third wall of the third ventricle. Tuberculous abscess is described as a representation, although we are seeing this presentation in our patient very frequently. Generally, they can have big size, usually more than 3 centimeters, with thin lobulated walls, although you also can see a small abscesses. This is a 5-year-old boy with multi-drug resistant TB treatment, and I show you here a multiple cystic lesion with peripheral enhancement after contrast. The main lesion has high signal in T2 and peripheral low signal in T2. There is restriction diffusion in the central of the lesion with low signal in the ADC map, showing us an abscess. This is another case, 13-year-old boy with TB contact, showing us involvement of the brain stem with multiple small lesion and a big lesion with high signal in T2. There is enhancement after contrast in the periphery of the main lesion and also in the other small, very tiny lesions surrounding within the brain stem. We did magnetization transfer imaging, which show us more enhancement in this sequence. In the restriction diffusion, you can see central foci of restriction diffusion with low signal in IDC map, showing us a small abscesses in this case. Miliary tuberculosis is mainly described in immunocompromised patients. Multiple small foci lesion of 2 to 3 millimeters with enhancement after contrast we can see. This is a case from the literature with multiple foci of enhancement in the brain. This is a case of 10-year-old boy with pulmonary tuberculosis. And here the patient came on March for an MRI of the brain, and we saw multiple small focal lesions with high signal in FLAIR in the left frontal lobe, right insula, and also in the left cerebral peduncle, and also in the right cerebellar hemisphere. And we couldn't add contrast by that time due to the administrative issues, and we suggested a follow-up with a contrast, and the patient came 1 month later. And I can show you the small dots of enhancement in the same areas of increased signal intensity in the prior exam, showing us miliary tuberculosis. Moving on to complications, hydrocephaly is the most frequent complication of CNS tuberculosis due to the meningeal involvement. This is a 5-year-old boy with headaches and diagnosis of tuberculous meningitis. And you can see here dilatation of the ventricles with transependymal edema represented as a high signal intensity of the white matter in both cerebral hemispheres, and also enhancement of the meninges in the basal cistern. Vasculitis and infarcts are also complications of CNS tuberculosis. Tuberculous vasculitis is considered an important etiology of stroke in the young. Vasculopathy is a consequence of the inflammatory basal exudate surrounding the arteries, and they are seen commonly as multiple bilateral lesions in the area of distribution of the perforating vessels of the middle cerebral artery. This is a 21-month-old girl with sensory disorder and TB contact, and I show you here the leptomeningeal enhancement, increased signal in T2 in the cortex from the right cerebral hemisphere, and the MR angiography show us multiple irregularities in the right cerebral hemisphere artery, and also thinning of in this area. Diffusion show us multiple diffusion restriction areas in the right cerebral hemisphere. Another case, this is a 5-year-old girl with ataxia showing us multiple foci of diffusion restriction with the corresponding low signal in the ADC map, and the MR angiography also shows us irregularity and thinning of the bilateral medial cerebral arteries. Finally, another complication is cranial nerve involvement, and is frequent seeing this complication in children. Up to 70% of the cases is due to the to infiltration of the exudate, compression of the tuberculoma, or due to involvement of the cranial nerve nucleus in the brainstem. This is a 10-year-old boy with neuritis of the third cranial nerve. You see here enhancement of the meninges surrounding the mesencephalon, also thickening and enhancement of the third right cranial nerve. So in summary, CNS tuberculosis affect principally meninges and parenchyma. And also consider, don't forget, complications. Meninges, remember, dural involvement, leptomeningeal involvement, and more frequently the meninges in the basal cistern. And the parenchyma, don't forget that tuberculomas are frequently in children, also in tuberculous encephalopathy and abscess. And don't forget complications, always check for them. Vasculitis, hydrocephaly, very frequent in meningitis, infarcts, and cranial involvement. Thank you very much for your attention. Questions at the end, right, Pablo?
Okay.
Yes.
Pablo?
Go ahead, Mariana.
Okay, so welcome everyone. I would like to say thank you all for having me here with you today. It's a very pleasure for me to be here to share with you some things about an important disease in South America, okay? So I will share my screen. And I'll talk a little about imaging findings in Ascaridiasis. Well, in the beginning, I would like to remember you some things about this disease. And I have to tell you that Ascaris is the largest intestinal nematode parasitizing the human intestine and one of the most common helminthic human infections worldwide. Well, knowing that, we can remember too that most patients with Ascaris lumbricoides or even Ascaris sum infection are asymptomatic, and the transmission occurs primarily via ingestion of water or food contaminated with Ascaris eggs, or even with the ingestion of uncooked food, right? Before I tell you and I show you some cases from our hospital and from friends of Brazil and South America, I have to give you a brief introduction about the life cycle of this worm. Well, we will ingest the Ascaris eggs from feces from contaminated soil, and the eggs will hatch the intestines through a gut wall and will migrate through the lungs via blood. Well, within the blood, the larva breaks into alveoli and travel up trachea, where they are going to be coughed up and swallowed again. And then in the intestine, they will pass through the stomach to the intestines for a second time, where they will become adult worms. And at this point, we will have symptoms and complications. So at this point, we can face clinical features like intestinal obstruction and even bad outcomes like this, like asphyxia because of the worms, because they can get through the esophagus and through the mouth, and can cause even death. So we would not like to face these bad outcomes. So in general, clinical symptoms occur among individuals with relatively high worm loads, and most often during the late phase adult worm intestinal stage, but also they may occur during the early phase, during the migration phase, as pulmonary manifestations. And at this point, we will have transient respiratory symptoms and eosinophilic pneumonitis. About the imaging findings, which is the important part of this lecture, I do not have any cases about eosinophilic pneumonitis, but in papers you can see that the most common findings are round and ill-defined infiltrates, like in this case. The opacities are usually migratory and bilateral. Now I will show you some beautiful and interesting but bad cases. So this is a courtesy of Dr. Antonio Soares Souza. He's the head of the pediatric department of the Children's Hospital where I work. And here we can see a 3-year-old boy with 3 days of history of abdominal pain, distension, and abdominal tenderness. And the X-ray shows us dilated bowel loops with multiple parallelolucent structures representing aggregated worms in the left flank. So it's important to remember that the number of worms in an infected individual depends on the degree of the exposure to infectious eggs over time. And there are case reports of more than 200 worms in individual children. And we have to look for and know what we're looking for to find these imaging findings. We have to be aware. At the same case, the patient got a clinical worsening and an ultrasound was performed, which showed us thick, free fluid in the peritoneal cavity. And the kid went to a surgical approach where the surgeons could see intestinal obstruction. It was a jejunal obstruction and perforation by the worms with a large amount of free fluid and a large amount of free worms in the peritoneal cavity. In this other case, which is a courtesy of Aníbal Espinosa from Chile, it's a girl with 2 years old presenting with vomiting, diarrhea, weight loss, and dehydration. And mother mentioned elimination of worms in this stool. The pediatrician palpable a mass in the epigastrium. And in the simple X-ray, we could see this large number of parasitic worms in the jejunum and in ileum with tram-track appearance, which correspond to this palpable mass in the epigastrium. And in these fluoroscopy images, we can also see that these worms are represented by elongated filling defects in the small bowel loops. Also, in this other case, from Dr. Yoshino from Brazil, from São Paulo, this kid was evaluated because she got congenital cystic dilatation of the common bile duct. And in this cystic dilatation, she got a large amount of these linear structures caused by this Ascaridiasis infection, okay? And when we have migration of adult Ascaris worms into the biliary tree, we can have symptoms of biliary colic, biliary strictures, acalculous cholecystitis, ascending cholangitis, and even liver abscesses, and we have to be aware. In the same patient, from Dr. Yoshino, we can see the adult worms in the lumen of bowel loops as echogenic tubular structures with this central anechoic tube, which is representative of a target sign, and it represents the adult worms. In some cases, during the ultrasound, we can also see curling movements of the worms. And if the worms, it's another important thing to say, ingest feces or even barium in a fluoroscopy exam, this content can be seen in their alimentary canal as a central echogenic line inside the worms. And it's very interesting. Another interesting thing about the Ascaridiasis worm is that we can understand and detect if it's a female or a male worm because of this ultrasound structure. If we see 3 structures inside an axial section of a female Ascaridiasis worm, we will see 3 structures. One of them will correspond to their intestines, and 2 of them will correspond to their reproductive system will be representative of their uterus. So we can understand if we are facing a female or a male worm. In this other case, from Rio de Janeiro, from Dr. Tatiana Fazecas, we can see a cine ultrasound, and we can also see here the worms inside the bile loops moving inside it. So it's very bad to see this, but we have to be aware to detect, and we have to know what we are looking for to detect this parasite. Okay. I have another case to show to you. This is the same case we showed previously on the ultrasound, the cystic dilatation of the common bile duct, the worms in the intestinal loops, and here we can see again the worms inside the cystic dilatation of the common bile duct. Okay, we can see this as linear low intensity filling defects with characteristic 3 parallel line appearance. Okay, and this is the last case I would like to share with you. It's a 4-year-old girl presenting with headache, abdominal pain, low fever, and irritability and weight loss. And mother also told us about recent elimination of worms through the nose, and she was under treatment for bronchitis. Here in the liver, in this ultrasound, you can see that we do not have a large amount of dilatation of the biliary tree, but we can see the gallbladder full of the worms. And in the liver, we could see this ill-defined imaging, an hypoechoic imaging, which is representative of an abscess. And this kid got clinical worsening, and she underwent a tomography, and we can see that she evaluated with dilatation of the biliary tree and with large abscesses, liver abscess. Okay, so it's a bad evolution and complications about ascariasis. Just to remember you, we have a high prevalence in underdeveloped countries because of the poor hygiene facilities that favors the spread of the infections. The major prevalence is in Asia, and it's a disease most common among children to 2 to 10 years old because of the contact of the soil, and they usually play with these things. In tropical countries, we have warm and wet climates which favor transmission, and the diagnosis is usually easy. We just have to look for the sputum, looking for the larvae, and look at the feces. Feces can be examined looking for the eggs and the adult worms, and they are simple. These exams are simple and very effective. We also can find eosinophily as an indicator of parasitic infection, okay? So for prevention, always we have to keep good sanitation conditions. Vegetable should be washed and food properly cooked, fingernails regularly cut, and hands properly washed. Just remember that eggs can survive for up to 10 years and are resistant to chemical water purification, but they may be eliminated by filtration or simple boiling, so it's easy to prevent. And modern sanitation, waste treatment, and education are the best alternatives for us. Okay, thank you. Now, Carlos Ugas will start with his lecture for us.
Thank you, Mariana. Well, I'm very happy today in this webinar from the ESPR and also with the Slarp. So we three are very happy, very excited to show just a little about our experience in South America. So I will talk about pediatric hidatidosis. That is still important infection in some areas, especially in the south of South America and high altitude areas. When we found cattle, that is very important for the transmission. So I have no disclosure, and the goals for this lecture are three. First, briefly review of epidemiology and pathophysiology of this disease. And most of the time, I will show you some cases, typical and atypical. And the presentation of the cases are basis of the location and the stage of the cyst. And finally, I will describe some complications. So hidatidosis is caused mainly from Echinococcus granulosus, and the distribution is worldwide, especially in cattle regions. And the presentation is usually abdominal pain or abdominal mass, but sometimes it can be just an incidental finding. And for diagnosis, we use laboratory tests, but also imaging. Just to remember the life cycle, the definitive hosts are dogs, and they spread the infection through the feces to the cattle, like sheep, goats, sheep, and finally, all the process occurs in the bowels of this cattle, and every organ in the body can be infested. And this feature is just to remember the morphology of this parasite. When the parasite is intact, we have a pearly cyst. In the development of this parasite, they will have some daughter cysts. And when this daughter cysts destroy, we will have hidatidosis. So we will find this in imaging. So the two important things for the pattern are location and the stage of the cyst. So the most common location is in children are lungs. So pulmonary involvement is the most common in children, also in our countries, because there is some mechanisms that influence high altitude, more pulmonary blood flow, and we have like a lot of cases in the lungs. The second most common site is liver, but through the blood, it can be to any organ, spleen, heart, kidneys, whatever. The other important thing that determines the imaging are the stage of the cyst. So when the cyst is intact, we will have a poorly cyst. Then in the development, we will have daughter cyst, we will have some signs of degeneration, and finally we will find something like that, this irregular solid mass, and sometimes with calcifications. So, well, the most important thing is to show you cases. And let's start with pulmonary involvement. This is a 5-year-old boy. And as in every pulmonary involvement, X-rays is very useful. We can see here 3 huge masses. And in the CT, we can see that these cysts are in different stages. This is a pearly cyst, and this cyst has some kind of degeneration with detachment of membranes. The second most important site on infection is liver, and ultrasound is key for proper diagnosis and follow-up. And we see here a huge cyst, pearly cyst, an intact, a viable parasite here in the ultrasound and also in a CT. Ultrasound can help us to look for these beautiful signs, as this is called water lily, because remember, as this flower, this is water lily sign that is secondary to detachment of the membranes. And when the cyst has this rosette light, it's because the cyst has daughter size, yes. And inside of this daughter cyst, we will found hydathic sand that is pathognomonic of this disease. Also, it's very common to find pulmonary and liver involvement. This is the case with pulmonary, this huge cyst in the right lung and also in the right lobe of the liver, here in the CT and also in the ultrasound. After the thoracic cyst extirpation, persists the liver cyst with signs of degeneration with this detach of the membranes. And in this video, we can see here moving around the hydathic sand. This is pathognomonic of this disease. Well, now moving on to unusual locations. One of these unusual locations is heart. This is a 14-year-old girl that came to our hospital with shortness of breath, and the echocardiography reveals a multiseptated mass in the left ventricle that finally was an hydathic cyst. Also, this is another unusual case with this huge cyst. At the beginning, we think about congenital anomaly or whatever, but we have the surprise that finally was also hydathic cyst. So a huge hydathic cyst that underwent surgery in our hospital. And another unusual location is spleen. And this case is from Argentina. It's a courtesy from Agustina Martinez, and she helped me with this beautiful case, when we can see that the most of the spleen is we can find here this huge cyst with signs of degeneration. Talking about the complication, we can classify in just three main kind of complications. The first is infection, the second is seeding, and the third is rupture. So this is 13-year-old girl that came to our hospital with fever, cough, and we can see here this X-ray, and also we can see that the cyst is irregular, and around both this and the bases of the lungs, there are some signs of inflammation, infection of this pulmonary parenchyma. And while I remember a lot of time, this case is like 10 years ago, and we had this skinny girl in very general bad state, and she has a lot of cysts in all over her body, especially in the peritoneum, in the peritoneal cavity. She has peritoneal seeding and cysts in multiple stages, and also a migration of the cysts, transdiaphragmatic migration from the peritoneal cavity to the lungs. We can see here the images of the ultrasound, but well, it's finally she gets well. She underwent a strong, intense therapy of antiparasite treatment and also surgery, and the outcome was very good. And the rupture can occur at the lungs and also at the liver, and spread to the pleura or to the biliary tree. So here we can see a cyst with degeneration that had a rupture and spread to the pleura. So in summary, we must remember that Echinococcus granulosus infect dogs, and they infect cattle, and finally, this is us. And the most common locations are lungs and liver, more than 90%, but it can occur in every organ. And the patterns of the imaging depends on the cyst stage. And the range is from a purely cyst lesion to a mass-like lesion with calcification. And also we will see rosette light, daughter cyst, hidatic sand. And the complications are mainly three: rupture, infection, and seeding. Well, since so much, it's very important to be aware of the disease still in South America, because a prompt diagnosis will avoid life-threatening complications. So thank you so much.
Thank you very much, Carlos, Mariana, Claudia. It has been fantastic cases. I really love them. We don't see them often. It's very rare to see them in Europe. I just remember that I saw recently a loafer case of a child who came from Brazil, and it's exactly what you told us. Is they are like round nodules in the lungs with ground glass opacity around them, and in a child that classically has high eosinophilia on the blood test. It's exactly what you said. So for the attendees, you can write your questions in the panel here. We can start with some questions. I have one for Claudia. Claudia, I have seen your cases of tuberculosis. We have seen in here some of them. It's not very frequent. And we have always the question to distinguish them from embryonal tumors, like you know that the embryonal tumor like medulloblastoma or ATRT, it gives this seeding or this spreading in the leptomeninges that is quite similar. Any tip to distinguish between them?
Well, I would say first, the epidemiology. Always ask for any TB contact. It's very important, the clinical history. And spectroscopy in the case of tuberculomas can help us because the peak of lactate is very high comparing to other tumors, because choline can be increased in both. But I think lactate is very high in tuberculomas. And also the enhancement is very heavy. It's a lot of enhancement in tuberculosis. Embryonal tumors also have enhancement, but I think tuberculosis or tuberculomas has a lot of more. And when it's easier, I think, when we have abscess suspicious within tuberculosis too, right? So I think those could be good tips to recognize or differentiate embryonal tumors from TB, CNS TB.
Thank you very much, Claudia. I have a little more short question for you. It's about the technique, because I have seen you have used a spectroscopy. That is something that I don't use very often, and that you use MR angiography. Do you always do them, or do you do them depending on the clinical question?
I use them depending of what I found with the patient on the MRI machine. When the patient is on the MRI machine, we always check the images, and if I saw foci of focus of diffusion restriction, I would add MRI. Also, if we saw like in the FLAIR images, you can see the thinning of the meninges in the basal cistern. So even we should do MRI before the contrast. If you see this very thick meninges in FLAIR, you have to suspect that this is a meningitis for TB, and you can add the MRA before the contrast. And in the cases that we already added the contrast, we also do the MRI before contrast, and just to check the just to see the irregularities and the thinning of the cerebral arteries. So really it depends on each case. We have to check and review all the cases before they stand up from the MR machine.
Thank you very much, Claudia. Carlos, there are a couple of questions for your very interesting presentation. First, how do you distinguish between an hydatid cyst from a mesenchymal hamartoma of the liver? It's from Monica Rodero.
Well, first of all, I think that ultrasound is very useful to distinguish. For example, we have this, well, as Claudia said, it's very important, the clinical history. If the patient is from an endemic region here, for example, in my country, there are some regions that has always Hidatidosis. But it's, for example, it's from the north of the country, we never see Hidatidosis, just in the south of the country and high altitude. So the first important thing is to remember clinical history. And the second is to use ultrasound, because in ultrasound has different and some pathognomonic signs. As for example, well, I think that the most challenging when you have a pearl cyst that is not so easy to distinguish, then you can use laboratory tests. But if you have this sign like pathognomonic, like hydatid sand, or this water lily sign, or this daughter cyst, you can say this is hydatid disease, because you never found these findings in another pathology. So it's very easy when you have these pathognomonic signs.
Yeah, I have to add that, like Carlos said, that the mesenchymal hamartoma is a tumor very typical of the newborn and the very little child. So always go with your epidemiology. If hydatid cyst is something that you expect in an infectious context, but not in a newborn, in a fetus, in that kind of population, you will have to think about mesenchymal hamartoma.
Yes, most of our cases are like from 8 years to adolescents. We barely found these images in newborns.
We have one question for Claudia. How do you differentiate base of skull tuberculosis from sarcoidosis?
Well, we didn't have sarcoidosis in here in Peru. I think we saw just one case. It was a foreign case, was not from here. And really, TB is the enhancement and the thickening is for much more than sarcoidosis. And the clinical history is again our main tool to recognize or differentiate both, no? And TB here is like every day we saw one case at least of CNS TB. So it's something that we always we are thinking every day in that pathology and also on its complications. So I would say that this could be one differentiation between both. I don't know you, Pablo. I suppose you see more sarcoidosis.
No, I don't think I have seen ever a case of sarcoidosis in a child here. And tuberculosis is also very rare here, so it's not. I have studied them, but I haven't seen them. It's not like something we see very often.
And I would say maybe one more differentiation could be the involvement of the hypophysis, right? And that could be another key to differentiate both, because and the clinical also, because the sarcoidosis has I don't remember how to say this in English.
So say it in Spanish. I will try to translate.
Que tienen muchas. Well, sorry about
okay.
this word, but I think this could be one differentiation.
Good. So for Carlos, we have another question. Is rupture mandatory for seeding? I also would like to tell your experience about the treatment. How did you remove this very big Hidatidosis in the brain without seeding it? Because I remember from my medical school that you have to remove the entire thing in one piece. That is very, very difficult.
Yeah, I guess so. Well, rupture is mandatory for seeding. The patient that we show, she has rupture of the disease, and she has a history of a lot of time with this disease. So to have a seeding, first you have a rupture, and just well, I just know that our surgeons, our neurosurgeons, told us that was really hard, the surgery to remove, to be everything intact, to not spread the disease. And I think that they also use just to prevent the disease, antiparasitic treatment like albendazole. I don't know if they use praziquantel, but I think that they use just albendazole, and all the recovery was good for these two cases.
Mariana, we have not forgotten you. So I have one question for you. With ultrasound, do you always scan like we do the intestines? When do you think, when you will start thinking that this could be worms in the intestines? Any tip for the beginners or for the countries that we don't see that very often?
Okay, well, the first thing, as Carlos and Claudia said, and you said too, is the clinical features. If you are starting to think about the clinical features, maybe you will think to look for the worms in the small lobes. And when you see linear structures, of course, sometimes we can see some medications, that oral medications that the kid has just received in the emergency room, but it's short and doesn't have any movement. But when the kid has a clinical feature of obstruction and you are looking for, and you see a large amount, many structures elongated, right one beside the other, you have to think there is no one specific thing, but when you see something like a noodles, you have to remember and you have to think about it. But the clinical features are the best, is the key to the diagnosis.
Thank you very much.
But it's not difficult to evaluate it, yes, as you saw in the class, in the lecture.
Yeah. Would you look more in the ileum, or is in the jejunum, or is everywhere?
In the jejunum. The jejunum is the frequent part of the intestine that the worms will be found.
Very interesting, because we always focus very much in the right lower quadrant because of the appendicitis and all the pathologies there. But
yes, that's because in the jejunum, there will be large amount of worms, but they can obstruct the appendices and they can obstruct the ileal valve. So you can find it too at this part of the intestine, but the large amount will be in the jejunum because of the life cycle of the Ascaridiasis.
That's really interesting. So, Carlos, there is one more question for you. Would cryptococcis be a differential for Hidatidosis?
Well, we don't have a lot of cryptococcis, but the only one cases that we show at the brain is like very different, because was polycyst that is different to cryptococcis, and also is very different at the lung. So I don't think so.
Yeah, it looks more like punctate lesions. It's more like
cyst.
Yeah, more than a big cyst like in Hidatidosis. It's a very different appearance.
Yeah. All of the cases that we see here are like a huge cyst, so it's not challenging the diagnosis. The most important thing is to be aware for the complications.
Perfect. So I think we have finished with the questions. Do you have something that you would like to say to conclude the session? No? Okay, so I will remember to our audience that next week we will have a new webinar about ethical and responsible artificial intelligence by Bianca Score and Emma Colina from Cambridge, the United Kingdom. It's a very important and interesting topic. And to remember that next month is the annual meeting of the European Society of Pediatric Radiology and the postgraduate course that will be in Belgrade in Serbia. And we would like to invite you, or all our friends from South America and our friends from Europe and all over the world, to go to Belgrade from the 5th to the 9th of June. And I would like to finish say thank you very much to Mariana,
Thank you,
to
Pablo.
Claudia.
Thank you.
Thank you
To
very
Thank you,
much.
all the
It has been an
persons
honor and a
that are
pleasure for
listening.
me and for the ESPR to have you here.
We
Thank you
would
so
like
much.
Nice to
Thank you
see
so
you,
much.
huh? See you.
Bye.
Bye.
See you.